John. Today we have a webinar that will be focused on the posaconazole pharmacokinetics and pharmacodynamics in specifically acute myeloid leukemia patients. And the speaker will be Dr. Silvia Corcione. She is an infectious diseases physician. She comes from Turin, from the Molinet Hospital. And yeah, it's a pleasure to have you here, Silvia. So please, the floor is yours. And yes, to remind you everyone, you can start already typing questions in the chat and we will read all of them afterwards. Thank you.
Thank you very much. Good afternoon, everybody. I'm really glad to be here today, so thanks for this kind invitation. I'm going to share my presentation. Okay. So today we're going to talk about the pharmacokinetic of posaconazole, and we will focus on several aims. We will start about the incidence of invasive fungal diseases in acute myeloid leukemia. Then we'll discuss a bit about the rationale of antifungal prophylaxis in acute myeloid leukemia, and then we will move to the characteristic of posaconazole and the role of therapeutic drug monitoring in the setting of ASL treatment and prophylaxis. And then I will show you some data regarding a new strategy for prophylaxis and maybe a bit comments on the antifungal stewardship that I think it's really important, especially in the setting of hematological patient. So when we talk about incidence of invasive fungal diseases in hematological setting, we know that invasive fungal diseases affect up to 11% of all hematological patients, and the rate of invasive fungal diseases in this setting has been completely changed or decreased thanks to the introduction of prophylaxis, antifungal prophylaxis, but also thanks to the microbiological diagnosis that we have so far, like biomarkers of new techniques that allow us to detect and identify invasive fungal infection better than before. Acute myeloid leukemia is the hematological disease with the highest rate of invasive fungal diseases, with an incidence rate of ranging from 10% to 25% according to the different epidemiological studies. In fact, when we look into the different patients who might be at risk for invasive fungal diseases, we can identify patients with low risk, intermediate risk, and high risk. And as you can see here for all the slides from a paper from Pagano, you can see that acute myeloid leukemia is among the patients with the highest risk of infection. As an infectious disease doctor, I like to stress how the epidemiology of invasive fungal diseases has completely changed in the recent years, because now we can consider patients at risk for invasive fungal diseases, also patients outside the hematological setting. For example, we learn about COVID-19 and the impact of invasive fungal diseases in severe COVID-19 infection, but also if we move into the setting of hematological patient, we have to consider the impact of monoclonal antibodies, CAR-T therapy, or bispecific treatment in this field, in which we have so much to learn about the risk of infection. But let's focus on acute myeloid leukemia. AML is a very heterogeneous disease, and the incidence of invasive fungal disease in this population is related to different risk factors that we can classify as disease, leukemia-related risk factor, host-related risk factor, but also treatment-related risk factor, especially the prolonged neutropenia and the mucositis, and also the fungal exposure. We have to consider, especially for Aspergillus, that recent house renovation, building construction, or renovation are some risk factors for pulmonary aspergillosis. So we can stratify patients with acute myeloid leukemia according to these four risk factors related to leukemia, host characteristic, treatment-related factor, and fungal exposure. That's why, according to this data about the incidence in acute myeloid leukemia, that primary antifungal prophylaxis is now considered the best strategy to prevent invasive fungal diseases in this patient population. And especially mold-active antifungal agents are the preferred agents for some patients at high risk. These are the EHA new guidelines that recommended posaconazole with a grade of evidence really high because it's A1 recommendation as a strategy for prophylaxis in patients with acute myeloid leukemia. So let's move a little bit deeper into the characteristic of posaconazole. Posaconazole is a systemic triazole antifungal drug, really similar derived from itraconazole, so has the same antifungal mechanism of action as other azole. And posaconazole has three formulations. We can use the oral suspension, the delayed release tablet, or the intravenous formulation. And this is quite interesting because we will see later on this presentation that pharmacokinetic characteristics are really different in those three formulations. So we have to consider which type of formulation we use to adapt antifungal prophylaxis and treatment. Posaconazole is today approved for prophylaxis of invasive fungal diseases in acute myeloid leukemia who receive remission induction chemotherapy, all the patients undergoing allogeneic cell transplant with high dose of immunosuppressive therapy for GVHD, or patients at high risk for invasive fungal diseases. But we have to take into account that it is also approved for oropharyngeal candidiasis or other rare fungal infection as a salvage therapy. I would like to move a little bit deeper into the different formulation. We can say that at the beginning, the posaconazole was developed as oral tablet table here. But after the development of this tablet, what they found is that there is a dose linear exposure of the antifungal, but there is not a linear absorption. And so the development of the oral tablet was stopped because the absorption was not linear, maybe due to the fact that posaconazole may be affected by the role of pH in the gastric tube. That's why they moved to the oral suspension that is now available and is in the market. But in the oral suspension, we still have an high individual variability. So there is a variable absorption limits compared to the oral tablet. And then they developed the delay release tablet, the gastric resistant tablet that have been developed to release posaconazole in the small intestine with the aim to avoid the gastric issue. That's why the delayed release tablet has a better absorption and a lower variability between patients. Despite that, still we have a lot of issue because there is interpatient variability along through all the new formulation, but the tablet should be less affected by the absorption issue. And then we have the intravenous formulation, which is created for patients that who are unable to take oral medication, in which there is still a little variability, but of course, with the intravenous formulation, the issue about the absorption is lower. For all those reasons, you can see here how the different type of administration needs to be managed according to the food. That means that, for example, the tablet, the delay release, needs to be administered preferably with food to get a bioavailability of 54%. If you can see here, the oral suspension is still more complicated because we need a high-fat meal in order to get a good bioavailability. So those changes may influence the pharmacokinetics of the drug. Another interesting issue about posaconazole is that it's a strong inhibitor of cytochrome 3A4, and this is the issue about drug-drug interaction. And it has a high protein binding. 19% of posaconazole is bond with albumin, so there is high protein binding. The mechanism of action of posaconazole is similar to the other azole, as I mentioned before, and inhibits the lanosterol, so inhibits the biosynthesis of ergosterol, which is an essential component on the fungal cell membrane. And in this way, the posaconazole inhibits the creation of the fungal cell membrane, and so inhibits the fungal growth. Regarding activity, posaconazole has a broad in vitro activity against Candida, but also Aspergillus, Mucorales, and some Fusarium species, with different MIC breakpoint shown by EUCAST. In my opinion, there is an interesting part of posaconazole since it shows a potent dose-dependent antifungal activity in vivo, correlating with efficacy. And even in the setting of some azole resistance isolate, posaconazole has an in vitro activity. So we might increase the dosage and still use posaconazole even when the MIC is available, because we know that not always MIC are available for fungi, sorry. We can still use posaconazole with increased dosage. There are two main routes of resistance regarding azole, which is possible induced therapy resistance or environmental issue for exposure. Regarding tissue distribution, posaconazole has a good distribution in several tissues, especially lung, kidney, liver, and heart. Also in the epithelial lining fluid, so in the lung, concentration are good, despite are slightly lower than in plasma. There are some data about the penetration of posaconazole in CSF, but still we need more data, especially because we have to discuss about the ability of posaconazole to penetrate in a blood-brain barrier, which is damaged by the inflammation. So there are data about brain tissue concentration in animal models, less data, lacking data for human brain tissue penetration. Another two consideration to take into account, because we will go a little bit deeper later on in my presentation, are two pharmacokinetics, pharmacogenetics components of posaconazole. Posaconazole is a substrate of P glycoproteins, and inhibitors or inducer or alteration in the genes of P glycoprotein may alter plasma concentration. And also, as I mentioned before, we have to take into account the drug-drug interaction to the cytochrome 3A4 inhibition and UGT metabolism. Regarding adverse events, we have to take into account about the hepatotoxicity, which is quite low. 1 to 3% of patients may have an increase in hepatic enzyme, but we have to stress that so far there is no correlation between posaconazole exposure and hepatotoxicity. Maybe a posaconazole drug plasma level above 1.83 may be correlated with hepatotoxicity, but there is no data so far who support this strong relationship. And then the cardiotoxicity with the QT interval prolongation in 4% of patients, more or less, and a low rate of atrial fibrillation and other alteration in the EKG. So this may be associated with the co-administration of cytochrome 3A4 substrate. So we have to take into account that possible drug-drug interaction for the cytochrome 3A4 may lead to the cardiotoxicity of posaconazole. So just to summarize the data that we have different way of administration, tablets, preferably with food, oral suspension with different dosages that are clearly described in the EHA guidelines. So oral suspension is 200 milligrams 3 times a day, tablet 300 milligrams once a day with the loading dose on day 1, and posaconazole IV the same as a tablet. The bioavailability is around 60%. It differs between different formulations. High protein binding, inhibitor of the cytochrome, and this is the part that I want to stress now, the role of therapeutic drug monitoring. As recommended to all the azole drugs, there is the need of therapeutic drug monitoring when we use posaconazole. And guidelines suggest to perform plasma dosage of posaconazole within 7 days after the beginning of therapy. And we have also several data recommended the level of posaconazole in the blood in order to get an appropriate prophylaxis. So if we want to get our prophylaxis working, we need to have posaconazole level around 0.7, 0.9 microgram milliliter in the blood. And if we are talking about treatment, of course, the range of CTRAF needs to be higher. But today we will focus on the prophylaxis. So this is the range that we have to take into account when we talk about appropriate posaconazole level for prophylaxis. So why we need therapeutic drug monitoring? We need it because triazole are exposed to a lot of alteration. There is a lot of interpatient variability, and this is true not only for posaconazole, but also for example, voriconazole, and in some cases also for isavuconazole. And we know that the risk of failure in our prophylaxis may also due to inappropriate serum concentration. So if we do not have satisfied concentration, satisfied CTRAF of posaconazole in our patient, our prophylaxis may be not appropriate. And so we might have poor outcomes. We can select resistance. And in some cases, the higher level may be associated with toxicity. Maybe this is not the specific case of posaconazole, but for example, for voriconazole, this is particularly true. So for azole, we need the TDM, and especially IDSA recommends TDM for all the azole therapy for invasive aspergillosis, coccidioidomycosis, blastomycosis, or histoplasmosis. When we have prolonged prophylaxis, which is the case we are discussing today, and when we have to think about drug-to-drug interaction with azole. And then there is a huge definition of special population, for example, pediatric patient, ICU patient, obese patient, in which the therapeutic drug monitoring may help us to adapt the dosage of the drug and to get a satisfactory level of CTRAF of posaconazole. So we can improve our clinical outcomes if we going to be more appropriated with pharmacokinetics characteristic of a drug. And several data show, despite that and despite those recommendations, that the use of TDM is not so common performed in the different settings, and usually around 40% of patients included in those categories that I mentioned before undergoes to therapeutic drug monitoring during azole therapy. Here is one of the real evidence, real-world experience of the use of posaconazole therapeutic drug monitoring in oncological patients. And in this paper published in Open Forum Infectious Diseases last year, the authors evaluate the use of TDM in their cohort of oncological patients, so hematological patients, not only acute myeloid leukemia. But what they found is that above 22% of patients fail to achieve satisfactory concentration for prophylaxis. So those group of patients might be at higher risk for breakthrough infection or failure of prophylaxis. And I think it's really important because 30% of patients who fail azole prophylaxis means that we have to think about what to do next. Do we have to move to another azole? Do we have to change antifungal class in order to treat a possible breakthrough infection? So it's a really relevant question in terms of antifungal stewardship approach. And I think that if we move to work to a personalized medicine focusing on those settings, we can really change outcomes in our patient. In any case, according to this patient, we have 30% of patients who failed satisfactory concentration for prophylaxis, and in multivariate analysis, patients who have a low level of albumin and a body weight above 60 were found to be associated with subtherapeutic levels. So these papers show us how the low level, the hypoalbuminemia, is a predictor of subtherapeutic posaconazole concentration, but also patients with a higher body weight. In fact, when we move to talk about special population, despite the renal impairment in which intravenous formulation is not recommended because of the accumulation of cyclodextrin, if we look into lower exposure in high body weight dosing recommendation, several papers describe how obese patients above 120 kilograms are at high risk for lower posaconazole exposure. So those patients maybe need an increased dosage of posaconazole, or maybe those patients are patients in which we have to use TDM weekly, or in order to assess the trough concentration for prophylaxis. And in fact, the dosing recommendation in the setting of obese patient is trying to increase to 400 milligrams for patient above 120 kilos, and trying to get to higher target of Cmin or C-trough, either for prophylaxis or treatment. Another interesting setting is the new agents that we usually hematology usually use for acute myeloid leukemia, and as an infectious disease consultant, we often see patients treated with these drugs, in which the use of triazole antifungal prophylaxis is recommended. For example, patient treated with venetoclax for acute myeloid leukemia, the recommendation is a little bit lower, it's B2, but the use of triazole antifungal prophylaxis is recommended if neutropenia is more than 7 days. And there is also the recommendation of dose reduction of venetoclax in order to prevent toxicity. So what we know is that there is a lot of drug-drug interaction, even with these new drugs, that now we have to take into account. And also the venetoclax therapeutic drug monitoring could be a useful tool, if it's available, to better manage the dosage in those patients. And in this paper recently published about pharmacokinetics of venetoclax in patients with acute myeloid leukemia, the authors show how there is a strong drug interaction between venetoclax and azole, voriconazole, posaconazole, or isovuconazole. And what they found is that there is an increase in venetoclax exposure when venetoclax is given concomitant with either voriconazole or posaconazole, despite the venetoclax dose reduction. So here there is a huge room for antifungal stewardship and personalized medicine, in my opinion, because we have to learn how to better manage the drug-drug interaction in this setting. And with the co-administration of posaconazole and venetoclax, also the AUC, meaning all the drug that has been administered during the day, is increased. So we have to consider that despite the dose reduction, could be an increased exposure of venetoclax when we administer also azole at the same time. In the last part of my presentation, I would like to move to another interesting issue. We use therapeutic drug monitoring, and we are so focused about the CTRAF concentration in prophylaxis because we want to avoid the risk of breakthrough invasive fungal infection. There are a lot of papers showing the different incidence and risk factors for breakthrough infection. What we know is that there is an inter-patient variability of azole. So there are some patients who have lower dosage of azole in their blood, and those patients have a higher risk to develop breakthrough infection. And then there is a small amount of mold resistance to azole, which may justify the breakthrough invasive fungal infection. But if when we talk about intra patient variability of azole is something that I think it's everybody has seen in their clinical practice, the epidemiology of mold resistance to azole, it's really different according to the geographic area in where we work. So if we want to summarize the possible causes of breakthrough fungal infection, there are pharmacological causes, and if you can see here, could be the non-compliance of patient to the oral primary prophylaxis, but also the insufficient intestinal absorption or inadequate therapeutic drug monitoring, the possibility of drug-drug interaction that may result in subtherapeutic fungal drug concentration, or maybe we are treating difficult to treat site of infection, brain parenchyma, cerebrospinal fluid, but also, for example, other sites difficult to treat, either also the lung, in which the ability to get satisfactory concentration may be not optimal. And the other issue are microbiological issues. So, for example, we have pathogen resistant to the prophylactic antifungal drug, or when we talk especially about Candida and Candidemia, the colonization by fungal pathogens of central venous catheter. So this is a different issue, more related to Candidemia and not mold, and not Aspergillus or other fungi. Recently, there is a really nice systematic review published on clinical infectious diseases who evaluated the breakthrough invasive fungal infection in patients with high-risk hematological disorder who receive voriconazole and or posaconazole as prophylaxis. And what they found is that breakthrough infection occurs in from 2 to 5% of patients, and the more frequent reason for antifungal prophylaxis failure could be suboptimal pharmacokinetics and infection with azole-resistant species. But as you can see here, the interesting part, in my opinion, is that the therapeutic drug monitoring was available only in 84% of cases, and this is a big systematic review, in 30%, 36% of cases, the concentration of azole were not satisfactory. So there is a big issue about the role of TDM, the use of TDM, and the ability to get satisfactory concentration of azole. And here you can see in the table what I was talking about a little bit earlier. When we have a breakthrough invasive fungal infection, what we have to do? We have to switch class in order to think about infection due to an azole-resistant species, We can continue the azole and change it maybe from posaconazole to voriconazole or isavuconazole, or we have to do combination therapy. So if we improve our ability to optimize the pharmacokinetic of posaconazole in acute myeloid leukemia, maybe we can also improve our therapy when we move from prophylaxis to treatment. And in this nice systematic review, what they found is the largest data collection on breakthrough invasive fungal diseases. The most prevalent EHA, of course, was aspergillosis. There is a role of pharmacokinetics in this setting, and the author concluded that there are a lot of work to do to identify the characteristic associated with the patient who develop breakthrough invasive fungal infection in order to get an optimal management. So in my last slide, I'd like to show a work that we did in the last 2 years here in Torino, in Turin, in collaboration, of course, with our great hematological group, microbiologists and pharmacology lab, when we try to combine pharmacokinetics and pharmacogenetic of posaconazole to improve the prophylaxis in patients with acute myeloid leukemia. So just to go briefly into the study that I think I would like to discuss to you, we start from the idea that we are facing so far. So there is the risk of antifungal prophylaxis failure, and the reason for failure is not fully understood. Could be suboptimal pharmacokinetics or azole-resistant species. And the breakthrough infection still occurs in a small amount of patients. So we decided to perform a prospective observational pharmacokinetic and pharmacogenetic study in our hospital. We collect all the CTRAF concentration of posaconazole 300 milligram in tablet here from the beginning of prophylaxis and until the prophylaxis was stopped according to medical advice, and we describe plasma level and genetic polymorphisms of the most relevant genes for who may interact with the cytochrome 3A4 in order to evaluate possible correlation between posaconazole plasma level, genetic polymorphism, and the risk of breakthrough infection. So our idea was based on the fact that maybe the risk of breakthrough infection is due to the failure of CTRAF concentration, but also because there is a kind of a pharmacogenetic profile of a patient who may promote the failure of prophylaxis. So what we do, we enroll 100 patients, and a lot of patients receive, more than 73 patients receive drugs with potential drug-drug interaction, and 19% of our group develop a breakthrough invasive fungal diseases, which was classified according to the ORTC criteria in probable 1 cases or possible in 17 cases. A lot of patients receive venetoclax. 50% of our population receive venetoclax as a therapy, and here you can see the characteristic of the patient. We evaluate at several time points the plasma posaconazole plasma concentration, 7 days, 14 days, 21 days, and then 28 days. And the majority of breakthrough infection were reported at day 7 and day 14, and then at day 21. Here you can see the switch. The majority of patients move to amphotericin B once the doctor who was in charge for the patient defined the breakthrough invasive fungal infection. What was interesting that we found that, of course, patients who develop breakthrough invasive fungal infection has a lower CTRAF posaconazole level at day 7, and this trend was confirmed at 14 days from the beginning of prophylaxis. And in general, we observe a lower median CTRAF posaconazole concentration in patients who develop breakthrough invasive fungal diseases. Then we move to the pharmacokinetic analysis. The pharmacokinetics analysis show that the CAR540TT genotype was associated with low posaconazole exposure. And also in the regression analysis, the predictor of low exposure was this genotype, higher body mass index, and the venetoclax co-administration. Just a small comment about the CAR genotype, because I'm not sure everyone is familiar with that. Also, I'm a clinician, so we need the help of the pharmacogenetic lab in this setting, but the CAR is a receptor, nuclear receptor, which regulates the expression of the cytochrome 3A4 that we mentioned before when we talk about posaconazole, but also, for example, the transporter like the P-glycoprotein, which is encoded by the gene ABCB1, and other gene involved in the posaconazole metabolism and transportation. So what we found is that if you have one allelic mutation for this genotype of the CAR, which mediate the expression of the cytochrome 3A4, we have patients with a higher probability to get lower level of posaconazole. And so this is quite interesting because we can create a kind of a pharmacogenetic profile of a patient who may be at higher risk to develop lower concentration of posaconazole, and so may be at higher risk to develop breakthrough invasive fungal infection. Then we move to another analysis. We will perform a sub-analysis of patients who had posaconazole exposure above the CTRAF cutoff for prophylaxis. So according to recommendation, those patients had a good level of posaconazole in their blood. But despite that, they develop a breakthrough fungal infection. So we get into the pharmacogenetic analysis to understand why 9 patients, because it is a small amount of patients, 11% of patients with satisfactory CTRAF concentration develop a breakthrough infection during posaconazole prophylaxis. And what we found is a kind of protective genotype for some patients. So patient who has a combined genetic profile regarding the ABCB1, which is the gene who translate for the glycoprotein P, and the UGT, which is another enzyme, which is the glucuronosyl transferase. Those genotypes did not develop a breakthrough invasive fungal diseases. So there is a combined genotype who may be potential protective for the breakthrough invasive fungal infection. So what we found in our study is that we confirmed this high inter-individual variability in posaconazole level, and the lower concentration are related to an increased risk of breakthrough invasive fungal diseases. But there are some pharmacogenetic characteristics that may identify patients who will be characterized with lower level of posaconazole and higher risk of breakthrough invasive fungal diseases. Why this is important? Because I think that we can consider that we can move to a personalized medicine in this setting, integrating therapeutic drug monitoring, maybe with pharmacogenetic analysis. And if we will be able to identify patients at highest risk for unsatisfactory posaconazole level and higher risk of breakthrough invasive fungal diseases, we can move to a better prophylaxis, antifungal prophylaxis, meaning that, for example, this patient can be treated with a higher dosage of posaconazole, or, for example, we can also decide that those patients maybe are not the right patient to use the azole after azole approach. Those patients at the highest risk for breakthrough invasive fungal disease are patients in which we have to move from azole to another class of agents. Just to conclude my presentation, I would like to stress that there are a lot of upcoming treatment options in the setting of fungal infection. So even in the setting of prophylaxis, I think we will be able to move to different strategies when we include new drugs like chlorophyll or rezafangin, who has the ongoing trial on prophylaxis in stem cell transplant recipient, and all other different drug which may be active against different fungi and might be possible new option not only for treatment but also for antifungal prophylaxis, and may help us to change or adapt our clinical decision according to the characteristic of our patient. Thank you very much for your attention.
Thank you very much, Silvia. Very nice presentation. So now it's time for questions. We have 5-10 minutes. So in case everyone has a question from the audience, please feel free to raise your hand, and Silvia will answer to it or to them.
I will try to answer.
So first, I have one question myself. We have spoken, or you have spoken about posaconazole, but for example, how different are the pharmacokinetics and pharmacodynamics of other triazoles or mold active triazoles as compared to posaconazole? I mean, like the information we got today for posaconazole, is it useful or similar to the other mold active triazoles?
Sorry, I missed the microphone. Yes, they are all really similar. The drug-drug interaction is an issue with all the azole. I think that with the exception of isavuconazole, which is a little bit easier to manage. But despite that, we know that all the azole have a strong cytochrome activity. So it's important, especially for voriconazole, for example, to know the cytochrome 2C19 to identify patients who maybe not get satisfactory concentration. So azole are really similar to each other in the way they act, with the exception of isavuconazole or fluconazole, but I think fluconazole is not to be mentioned in this setting because it's not mold active. So with the exception of isavuconazole are really similar. Despite that, we have to mention that guidelines recommended therapeutic drug monitoring even for isavuconazole when we have patient who may have difficult to treat infection like the brain or other site of infection that are difficult to reach, or patient who did not respond to therapy, or patient, for example, critically ill or other settings. So I think even if at the beginning we thought that isavuconazole were completely different, it was so easy to manage, now we have to take into account that also for isavuconazole we need, in some cases, TDM. But compared to voriconazole or posaconazole, in which TDM is recommended almost for every patient in which we are use it, maybe we have some space in which we can avoid TDM for isavuconazole.
We have one question from me. So, is drug-related genetic test done for everyone diagnosed with acute myeloid leukemia?
No, thanks for this question. I wanted to show this data because I think was nice to include the pharmacogenetics in a setting in which is not routinely performed. So this study, these pharmacogenetics analyses were performed in a protocol of a prospective study. Our idea is to move now, we have submitted this data. Our idea is to move to a prospective study in which evaluate pharmacogenetics analysis of all patients when they start antifungal prophylaxis and try to to stratify patients according to their pharmacogenetic profile and moving from that, decide which type of prophylaxis or approach use in those patients. But it's not something that we can do like every day in our clinical practice.
And thank you. And I have another question. Like, for example, it's true and it's a fact that in some institutions they don't have access to therapeutic drug monitoring, but still they do administer posaconazole or voriconazole. What would you recommend them to, or how would you recommend them to proceed? Because it's a
Yeah,
recommendation
this
to
is
do the TDM, but if they don't have access to it.
Yeah, that's right, and this is an issue. I think the only way, if we don't have TDM, is to strict monitor our patient. So, for example, consider. I will start from the basis. So, evaluate, like if we go to the third slide, we show the slide about risk factors. So, type of leukemia, characteristic of the diseases, host characteristics, and duration of neutropenia, relapse of diseases, and other relevant questions. So I will start from there. If our patient is included in one of those, one of those characteristics, this is a patient at highest risk for invasive fungal diseases. So I will start prophylaxis, and then if I don't have the chance to get the TDM, I will follow the patient more strictly. For example, if we use voriconazole, we can see if there is any drug-related toxicity. Sometimes it's easier with voriconazole because there is a stronger relationship between side effect and drug concentration. With posaconazole, this is less. There is less evidence about that, but still I will keep the patient on track to check if there's any relevant clinical issue that may let me think that the patient has not satisfactory value of posaconazole in their blood.
And also from MISO, and I guess it's following the genetic test, how long does it take to obtain the results of the test?
Yes, thanks. The genetic test is not so, it's easy to perform because you just need one EDTA sample. So it's just one blood test, it's not so much effort. And then the analysis, we usually try to put together a few samples and then run the analysis once for several patients. But when we run the analysis, we have the results in 1 week, 7 to 10 days. So the thing is to have a pharmacology lab who is ready to get this analysis. But I think it's feasible. We need the expertise. I always think that when we talk about those patients, we do so much effort, we do so clinical trial and protocol and new experimental drug, and when we move to anti-infective therapy, we always are really we are not so deep involved maybe in promote other investigational activity, while I think we can do a lot if we improve our strategy, either for prophylaxis or therapy in the infectious disease setting.
And the last question from my side, I mean, you mentioned that there are several formulations of posaconazole. The question, or the first question is like, are there differences in the penetration depending on the posaconazole formulation? And then the second question is, if you would have to choose only one of the formulations, which one would you choose?
Yes, thank you. There is a lot of differences. I didn't go deeper into the difference of the several formulation because I was thinking it was really too heavy to go into that, but yes, the bioavailability is different. The ability to concentrate, the ability to concentrate in different tissue may be different, and also, as I show you in the previous slide, the absorption is different. You need the high fat meal and whatever. So if I have to choose, I think tablet will be easier because you don't have to take care too much about the type of meal on time of administration. So the delayed release, I think, is gonna be easier because we avoid all the absorption issue that we have with other formulation.
Okay. So in case there is no further question from the audience, thank you very much again, Silvia, for your kind presentation, and to the rest of the audience, and also to Silvia. Well, we will see again in July in a webinar focused on Pseudomonas aeruginosa after CAR T, and in this case, there will be two speakers. I mean, it's the only one with two speakers who are Eleftheria Campouri and Guillaume Dashi. So thank you very much, and I wish you have a very nice end of the week. Thank you.
Thank you very much for your kind invitation.
Thanks.
Bye.